Hello and welcome everyone. Today we have quite a unique situation in that we're focusing on a publication from DC&R where we have the first and senior author of that paper with us. And I think that'll give us a very good opportunity to sort of delve into the paper in great detail. And then further to that, we'll extrapolate on the sort of greater pelvic pouch surgery discussion. So thank you for attending and hello for anyone watching on YouTube. This is, of course, our team with Dr. Galandiak being the editor-in-chief. So this is a brief discussion of description of the webinar etiquette. Should any of the attendees have questions, please text them and we will endeavor to discuss them in the chat. So, thank you. I would first like to thank Dr. Fleshner for hosting this session. So he has been very supportive behind the scenes and making himself available, and also inviting Dr. Evan Adams to be involved also. A few words about Dr. Fleshner. Of course, he has a main clinical and research interests directed towards optimizing outcomes in both Crohn's and ulcerative colitis. He is our special guest today, and so we will focus on his view of pelvic pouch surgery in that segment. The summary on this slide is just a short, brief list of his key achievements. Whilst I've been reading some of his bios online, there was one line that caught my eye in that Dr. Fleshner originally dreamt of becoming an airline pilot, only to have his hopes dashed by growing too tall for the cockpit. Sadly, I can't personally relate to this, and I suspect neither can Stephen Brandstetter, but maybe in the next life. Sort of an interesting fact about LA. So I learned that the LA County Coroner has a public gift shop called Skeletons in the Closet, which perhaps should have a arguably have a place in some of the surgical departments as well around the world. Anyway, now I will now ask Dr. Fleshner to have a brief chat about his city, the institution, and also introduce Evan Adams, who was his trainee. Thank you.
All right. Thanks, Vlad. Thanks for the accolades. I can't believe that's really me, but I'm at Cedars-Sinai, Los Angeles. I've been here for 35 years now. Los Angeles is a very interesting place to live, and I mean in quotations. It's got a lot of beautiful weather, but a lot of other problems, which we could talk about offline. But it is I've loved living here, and I've been really, really happy. And Cedars has really afforded me the ability to do pretty much everything I wanted, including research and academics and education, and obviously a clinical practice. So it's been really a lot of fun. Evan was a resident with us. He spent 5 years during his surgical residency. He also spent a year doing clinical research with us. He did a lot of really great stuff. For example, in ICG interpretation. Also, one of the things that he did, which is the article we're going to discuss today, is looking at an idea that all of us sort of think about, but don't really contemplate looking further than that. Like, we're always concerned about blood vessels in the operating room. We're doing J pouches because this is what limits our ability to bring the J pouch down from the abdomen all the way to the anal canal for a tension-free anastomosis, which is all what we want. And we sort of look at the blood supply, but we don't really analyze the blood supply and the vessels. So we had this idea that maybe there was something preoperatively on some of the imaging tests that these patients had, which Evan will go through, then maybe it can give us some insight into what we should expect from those patients when they eventually come to surgery based on preoperative imaging. So that's how kind of the study came about, as sort of as an introduction. And I guess, Evan, if you want to start, go for it.
So as Dr. Fleshner said, the real nidus for this project was trying to figure out if we could find a way to predict people that would either be very challenging pouches or people that were at risk for not reaching. As we all know, J pouches are a preferred modality for ulcerative colitis and IBD unclassified, and select patients with Crohn's disease, which we can get into. The important component of a J pouch is, as Dr. Fleshner said, to create a tension-free anastomosis. And that's important for both short and long-term function, preventing anastomotic leak and pelvic sepsis, but also preventing stricture. So a critical factor in being able to maximize both short-term function and long-term function is the ability to get the small bowel down to the anal canal in a tension-free way. Despite routine practice, this still continues to happen in up to 6% of cases in the literature. The factors that have been shown to associate with non-reach include male gender, obesity, potentially a two-stage procedure, and prior abdominal surgery. But there wasn't a great tool to actually predict who was at risk for that. So, given the way the small bowel mesentery is fixed to the aorta, we thought that one area of investigation that we could pursue is to actually use CT scans and to measure the distance of the mesenteric vasculature as far as we can trace it, and specifically the SMA as it becomes the ileocolic artery, and then its relationship to the distance to the anal canal. There was some precedent in the literature for people looking at this before, and in particular, there were two studies that I think really inspired us. One was a study that looked at the distance from the ileocolic artery to the anal verge and associating it with the number of mesenteric vessels that needed to be intentionally divided. And then the second one was looking at the distance from the ileocolic artery to the anal canal as a risk factor for conversion to a stapled anastomosis as opposed to an intended hand sewn, which also is a lengthening maneuver. So this was a single institution retrospective study, including IBD patients. It was predominantly patients that were three-staged, about 90%. Our inclusion criteria, the patient had to have a CT scan with IV contrast. We had to be able to actually see the CT scan, and the IV contrast had to be specifically protocoled so that we could have an adequate arterial phase. We also needed to have reconstruction in both the sagittal and coronal planes. What we did is we took these scans and we had board-certified radiologists blinded to clinical outcome take 3 specific measurements. And these measurements are really simple. The first one is the total length, and that's indicative of the length that the mesentery has to reach from the root of the SMA down to the anal canal. And really, this length is comprised of 2 other lengths. So that's your mesenteric length, which is what you're starting with. And the way we measured this is we just took the ileocolic artery as far down as it could be radiographically detected, and then measured that just in a vertical coronal plane. And then that length is in opposition to what we deemed the mobilization length. And the mobilization length is basically the distance that we have to surgically create from the terminal branch of the SMA down to the anal canal, which we used the top of puba rectalis to define that. Our cohort was there's 59 patients. Most of them were in their 4th decade of life. We had 6 non-reach events. Within these 6 non-reach events, we did have, interestingly, 3 patients with Crohn's disease. And the non-reach events were the overall population was generally about 2/3 male. Among the non-reach, 4 were male, 2 were female. And then in terms of surgical approach, 5 out of the 6 of the non-reach events were in an open fashion. And that comprised a little more than, that was about 60% of our cohort. We then look at interactions between clinical characteristics and our CT indices. Here you can see that there was a significant effect. This is looking at that total length, the mesenteric length, and the mobilization length, and we're comparing males to females in this top slide. And you can see that even though there's not a major difference in total length or a statistically significant difference in mesenteric length, the male patients needed about 3 more centimeters of mobilization length for a successful pouch, and that's consistent with male gender being a risk factor for non-reach. Interestingly, when we looked at BMI, we did not see an effect. And I think part of that is that, I would note there were only 3 patients in this cohort that had a BMI over 30. So that's what happens when you do a study in Beverly Hills. Similarly, we also looked at things like surgical approach, the way the anastomosis was created, a number of mesenteric vessels that were intentionally divided. And what we saw was that we needed a longer mobilization length, and there was a shorter mesenteric length for a stapled anastomosis, consistent with a lengthening maneuver. And there were sequentially a higher number of vessels needed to be divided with preoperative longer mobilization length. This is looking at CT indices actually between the reach and non-reach cohorts. And what I would say, what I would call your attention to is that while there was a longer total length in the non-reach cohort, it didn't reach statistical significance. But what we did see was a much shorter mesenteric length and a significantly longer mobilization length, almost 6 centimeters between the completed and the non-reach pouches. And that's really indicative of the significant effort that needs to be made to get those pouches down to the anal canal. We then, we wanted to look at specifically, what numbers may be helpful clinically to help predict non-reach. And so we did logistic regression, and we looked at, did area under the curve analysis with receiver operating characteristics curves. And the number that seemed like it had the strongest, predictive clinical applicability was a mobilization length greater than 17 centimeters. So needing to create 17 centimeters of length from the mesentery down to the anal canal was 100% sensitive and 69% specific for non-reach. I think there were several limitations of this study. The first is that we saw a very high overall rate of non-reach, and we speculate that that is related potentially both to referral bias as a tertiary center, and also potentially to the bias of patients that are getting CT scans potentially are at higher risk for non-reach. There isn't an actual indication for ulcerative colitis for a CT scan. And so that could have been part of why we saw a much higher rate of non-reach at 10% compared to the literature, the highest of which I saw was around 6. The second, I think, thing to think about is, there were a few patients with Crohn's disease in this cohort, which is something that's, I think, potentially somewhat unique to our center. And those patients did have shorter mesenteries. We did do some subgroup analysis, and the mobilization length as a predictor still stood out, even when we looked at only ulcerative colitis and IBDU, and it still stood up even when we excluded people that were 2-staged, which was potentially another source of bias. I think the other limitation of this study is, obesity in the literature is a major contributing variable for non-reach, and there simply weren't obese patients in this cohort to really be able to study. But I do think the combination of these length indices with obesity is potentially a intervenable preoperative variable that as a surgeon you do have some potential control over in terms of when you select these patients and consider them to be a candidate for when you actually do an elective pouch. And then finally, I think non-reach is a relatively rare event, and that inherently limits its statistical power. So in conclusion, I think what we've shown is that CT length indices are associated with non-reach events. Mobilization length consistently stood out as the most useful measurement. And it's the one that I think if you're considering using these measurements that I would encourage people to try to drill down and focus on. We did see that men had a longer mobilization length, which accounts to some degree in the increased difficulty that's seen in trying to do pouches in men. And I think this work was very consistent with the 2 studies that we saw that were published previous to it that showed that mesenteric length and mobilization length can correlate to the number of vessels that needed to be taken and the anastomotic type. Next slide. The conclusion that I would have people take from this study is mobilization length, as measured by preoperative CT scan, can be used to identify high-risk patients that are at risk of non-reach prior to J-pouch. Thank you for listening, and we'll take any questions.
Thank you very much for such an excellent summary. This paper really sort of stuck out to me because I was quite interested in pelvimetry, and in fact was involved in a publication about that for rectal cancer and the completeness of TME. So obviously not directly related to what you guys did, but I do like the trend in terms of the CT predictive values. My first question, sort of just expanding on pelvic pouch surgery in general. In your study, you mentioned that you aim for a pouch of 15 to 20 centimeters. Now, sometimes at conferences, particularly from Europeans, I hear that they are happy with much smaller pouches, like 10 centimeters. And so, what is your reason for that configuration, and what are your views on the smaller pouches? And I'll direct the questions to Dr. Fleshner, and then Dr. Fleshner, you're welcome to pick on Dr. Adams as you see fit.
Well, maybe Evan should answer that. I mean, he's nice junior attending. That was great. But, that we've always been taught, and almost always when you're in the operating room, I think we've learned that the maximal length that you get is 15 to 20 centimeters, sometimes even to 25. That's where the apex almost always lies the nicest. And that's why we've always chosen 15, 20 centimeters. We also, I think, chose that because it's always been developed like that because, we try as much as we can to, when we're doing these surgeries, to recreate, if you like, a normal rectum, which is 15, 20 centimeters approximately. So that's one of the reasons why I think we'd like to do that. The Europeans, however, you're right, they do much smaller pouches and their functional results seem to be comparable to what we're noticing. And I can't explain why. The problem is you don't want the pouch 40 centimeters because then it doesn't empty. But we've always been taught that you don't want really small pouches either because they don't have volume. So I think it comes back to sort of the points I mentioned before, what we've learned and what people have traditionally done, and just intuitively based on what's there naturally, so to speak, if you want to call it the 15, 20 centimeter pouch. I'm sorry, like a rectum, if you want. We call it a neorectum, which is 15 centimeters plus.
Thank you.
Evan,
Just
I,
to
Evan, I don't know if you want to add anything on that, but
Yeah, I think a smaller pouch, I would worry about functional outcomes and frequency, and it's just not something I've clinically done. I think the smallest I've gone is 14, 15.
maybe it may be, Vlad, and I don't make fun of the Europeans that way, but they have an extremely high leak rate, the Europeans. They accept leak rates in 10 to 15% in their published data, which I've always told that if I had a leak rate like that, I'd be called in by the front office, say, what's going on here? Maybe it's because, and I don't know for sure, maybe it's because these pouches are so small that they're under tension and they're being tethered in some way by when they're pulling them down. I don't know the answer to that. There's a lot of different reasons. A lot of the times they don't divert, which maybe we can talk about at some point. Maybe that's one of the reasons why their leak rates are high. But they accept that those leak rates are fairly higher than what we expect. I mean, at least what we would accept in this country.
Yeah, interesting. What do you think about the lumen of the bowel itself? Obviously, different small bowel has different capacity before you make the pouch. Some is 3 centimeters, some is sorry, 1.5 inches, one some is 1 inch. But there's definitely a difference in lumen. Yet I don't remember ever being taught to titrate pouch size based on that. Have you ever thought about it? Do you think there's any impact on this bowel size?
I don't. Sorry, Evan, I don't mean to take away from your thunder, but I don't think it is because, the natural adaptation that occurs in these pouches after the stool is after you take your ileostomy down, in a year, they all look the same. They're all basically, 3 times. I always like to tell the patient when they diverted initially, they're the size of your fist, but a year later, they're 3 times the size of your fist because of the anal muscle acting as a chronic, if you like, obstruction and natural adaptation of the area to try to absorb water and store. So I have not, and they're all very, very dilated. I mean, they're literally, I mean, I think all of you have seen either pouchoscopies or have you seen if you're in the operating room doing redo pouches, they almost always are very voluminous. So I don't think that the diameter is going to make that much of a difference. And I'm not exactly sure how you would potentially increase the diameter of the bowel anyways, even if you wanted to. I mean, you could do an enteroplasty, I guess, or maybe use different parts of the intestine and maybe a little wider. But I don't think that there's any very big differences between jejunal loops and ileal loops as an example in terms of the diameter.
Okay. The other thing that's commonly sort of debated at the same conferences is mesentery anterior versus mesentery posterior. Um, what do you do? And does the CT imaging impact that at all for you?
Evan, you want to attack that? I'll let you. I've been hogging the floor. I don't want to hog the floor.
Yeah, I think mesentery posterior for me personally seems to lay better. I don't think the length is necessarily that's my default, and I don't think the length is a major difference between the two. You're talking about maybe 0.5 to 1 centimeter. So that's my approach.
But there are times, I would agree, Evan, there are times when, I think just, again, it comes back to what I think just lays naturally. What lays naturally is the mes against the retroperitoneum. That's we were all sort of, even when you take the terminal ileum off, when you're doing the dissection, you're taking the terminal ileal mesentery, which is posteriorly, off of the retroperitoneum. It just seems like it's more natural. But there are times, I agree, that when you try to get length, and you can't, one of the things you can do is rotate the pouch and actually put the mesentery anteriorly, and it just seems to lay nicer. And if it does, go for it. I don't think that I have not seen any significant differences in either early or late outcomes in terms of whether or not the mes is either dorsal or ventral. I've not seen that.
Thank you. Next question I have is, in your paper, you mentioned that you aim for a J pouch length 4 finger breadths below the pubis. And then you also state that you perform internal mesenteric vessel division, and if that doesn't work, you proceed to an S pouch. And so what I want to clarify is the intraoperative steps of when you do these things, and particularly how that relates to when you do the proctectomy. Do you form the pouch first and then do the proctectomy, which is logistically more challenging? If you do the proctectomy first, it's a bit of a moot point what you then do because the pouch is either going to reach or not. So how do you do those steps?
Evan, you want to answer that, and I'll expand on it. Sure.
Yeah, so I think the first important point is retroperitoneal mobilization, and I think that gets you a lot of length, particularly in people that you're three staging. Mesenteric vessel division is, I think, an important. If you don't have enough reach, the first with retroperitoneal mobilization, the other option is pie crusting, can be helpful to get another centimeter or two, but the small bowel is very well vascularized, and oftentimes, as long as you can test clamp first at the place that and ensure that your pouch survives, but usually it can tolerate some mesenteric division, and that can help facilitate reach. Interestingly, in this paper, this had some people, but as part of our research here, we also did ICG routinely on, I think, 23 successive pouches, and none of them really showed any evidence of ischemia, either at the J-tip or at the apex. It's really a very well vascularized pedicle. So it can certainly tolerate some mesenteric sacrifice to facilitate reach. And then S pouch configuration, I think, is an option. For me, I think that's something that's, in a kind of last resort, bucket. And I've usually been successful with the retroperitoneal mobilization, pie crusting, and sequential mesenteric division.
So the only thing I would expand, I agree with those points. The only thing I would expand upon that is, this is the clinical scenario. You have the patient who has, let's say, the total abdominal colectomy, which most of these operations now are done as a three-stage. What I've done is I go in and I mobilize the terminal ileal mesentery and take off everything off the retroperitoneum and duodenum to really get length and assess what you're doing. I then bring it through the ileostomy site, and I see whether or not this is going to reach. If it's going to reach, obviously, or if there's a question, or if it's going to reach, I proceed on to the proctectomy. That's what I was basically getting to. If I know, and I've been in this scenario where the mesentery is so thick and it's not going to reach, don't go after the rectum at that point, because now you're going to end up burning your bridges and making your subsequent pouch and a pelvic dissection more difficult. And now you potentially might make your pouch and not be able to hook it back up. And now you're stuck in that typical board exam question. Well, now your pouches are made and you have no length. So in those scenarios, what I've done, if it's definitely not going to reach, put the ileostomy back, wake the patient up, and say, look, you have a number of options here. If they are a little chunkier than you want, if they have central obesity, put them on a GLP-1. Let them lose weight. If that does not work, then you have to have a discussion with the patient. I'm going to go back in and I want you to lose weight, but this time, if I can't do it, I'm either going to do an ileorectal, which is an acceptable approach with appropriate patient education, or you'll do an ileopouch rectal, Okay, where you'll actually go as low as you can, leaving as little at risk, if you like, or potential for disease mucosa. But at least you've had a discussion with that patient pre-op in terms of what to do in that difficult scenario. Okay, that's the way I manage that. If there's a question about the reach and you don't know, so there's three extremes. One, you're definitely going to reach, no problem. Two, I would proceed on with the laparoscopic phase. The second one is it's definitely not going to reach. The third one is you're not sure. When you're not sure, that's when I'll make a fan and steel incision. And I'll make a fan and steel incision and get a very good sense how much really length I really have. Because sometimes it's hard to assess how much length you have through the ileostomy site itself, because you're bringing it through the abdominal wall and you're making an unnatural curve along the anterior abdominal wall with the stoma. I'm sorry, with the stoma site. Usually we've looked at this and usually you add on about 2 centimeters in terms of what you can do through the abdominal wall. But still, if I'm stuck and I'm not sure, I'm still not going to commit to the proctectomy. I'm not going to commit to create the J pouch yet, but I'm going to make a fan and steel. And then I'm going to get a sense with my hand how much length I have in its anatomic position. And now if I'm stuck, I'm backing out. If I'm not stuck, I'm going to proceed on.
Thank you. That's wonderful. Just sort of further to the pouch rectal anastomosis, can you just describe for us to have on the recording what is an appropriate cuff for a double stapled pouch? How do you measure that? And what would be a pouch rectal? Like how big, what is the maximum you think is tolerable?
Evan, go
It
ahead.
could also be an evacuation issue, I assume, if it's too long.
Evan, go ahead.
Yeah, I think ideally you're, within, just above the anal rectal ring, not much more than that. In terms of what's acceptable, I think that's based on to some degree, your preoperative discussion with the patient, particularly if you know that it's a pouch that you're going to have, you've modified all the risk factors you can, and you're going to have trouble bringing it down. Um, um, and then sorry, what was your third? You had three questions.
The height of the ileal pouch rectals.
Um, I really have to defer to you on that. I don't have a
No
lot of
problem.
experience doing
So,
that.
so a couple things about, I agree with what you said. The cuff length in many ways now is becoming the Achilles heel of the operation. Because what we're noticing, and I think all of us are noticing this with minimally invasive procedures, we're trying not to make incisions. We're trying to somehow another open surgery now is like an anathema. It's like you're like killing a patient to make an incision. So what we're doing is we're now leaving these long cuffs. You're actually not even doing an iliopouch anal anymore. You're doing an iliopouch rectal, quite frankly. And that's then leaving this patient with this long cuff that you then call cuffitis, but it's actually not. It's really ulcerative colitis that's left behind. It's because it's an inappropriately done iliopouch surgery at the first time. So you've got to make sure that you're actually low enough. And there's many different ways to do that. The way that I do that is I put my finger in the anus when you're about to transect, and literally you should be no more than a 1.5 centimeters max above the dentate line. Or what I like to do is like the two to the PIP joint on my from the anal verge, not from the dentate line, from the anal verge. That's a very important distinction. Okay, you want to make sure that when we say you're 1.5 centimeters, that's from the dentate line, not from the anal verge and not from the upper anal canal. Okay, that's wrong. And you have to make sure about that. The other trick you can use, because sometimes it's hard to transect that because of the stapling techniques we have, is you have to push from the upstairs, from the bottom. If you push up with a fist, you'll actually notice that you can identify the lower part of the anus lower part of the rectum rather, in the upper anal canal much better, and then continue your dissection down if you really, in fact, have not gone low enough. Okay, that's what you should be doing, because otherwise you're not really doing a proper ilioanal pouch surgery. And in terms of ileal pouch rectals, again, in those select patients, you literally take it down to where it's easy enough that the anastomosis is not under tension, but you're leaving as little as potential at-risk mucosa as you can. And again, you can do an ileorectal. The Swedes have been doing ileorectals for eons, and they get away with it for reasons I never really understand. So again, with appropriate patient counseling and surveillance, You have to be careful, obviously, for example, with rectal dysplasia, you wouldn't necessarily do that. Or if they have a cancer in the colon, those are the kind of decisions that you have to make in terms of whether or not they're candidates for that. But if you have appropriate decision making in ileopouch rectal, basically bring it to where it's just easy. And at the same time, try to minimize the amount of at-risk mucosa that you're leaving behind. I think that's what you're asking, Vlad.
Yeah, no, thank you. I do completely agree in terms of the challenging with minimally invasive surgery being the transection, because we don't have a stapler that can transect the anorectal junction with at a right angle. So I think that's why it's so much harder to go low. Is there any role at the moment in your practice for a hand-sewn ilio pouch anal anastomosis?
Evan, go ahead.
Yeah, I think that's, the patient that has high-grade dysplasia potentially. Um, that person certainly has a role for a mucosectomy and then a hand-sewn anastomosis. And then I think the other scenario is, you go to bring the stapler up and you tear the distal cuff. And that's, I think, your best bailout option probably is to pull it down and hand sew it. Because you're not going to be able to realistically sew that up probably and fix it and be able to staple again.
So I'll make two comments about hand sewn. Number one, it's a fundamental skill that every colorectal surgeon has to know. And you have to know it because in those cases where you have rectal dysplasia, and you have to know it for what Evan said. If you have a technical problem at the time with your stapler coming through the stump, you're going to have a big problem sewing that thing back up from the top. And you're going to have to do almost certainly some variant of a hand-sewn anastomosis. So it's a fundamental skill that all of us need to bail ourselves out in those uncommon scenarios. Having said that, though, I just so that where I'm coming from, I used to do all my pouches hand sewn, and then everyone started saying, "Well, I'll start doing the staple," and I started to staple them, and yes, they're easier, and yes, they take less time. But then you know what I noticed? I noticed cuffitis, and cuffitis is a Achilles heel of the operation nowadays. That's what I mentioned before. Occurs in about a third to a half of the patients with no good really therapy. If you think about it, we try mesalamine suppositories, it doesn't work very well. You're basically doing an incomplete colitis operation. Now, we can argue till the cows come home in terms of function. I can have a discussion about that, why maybe it's not as obvious as you think it is in terms of why function's better. Having said that, though, I now, because of cuffitis, I'm starting to go back now to hand sewn, and I'm concerned about the patients that I never used to see with all these. I'm having pain, I'm having blood, I'm having mucus, and it's all related to cuffitis, which I never used
That
to see
that
with a hand sewn. So the
that's
way that
fair.
I've been approaching this now, at least my practice, is that if the patient looks like the pouch is going to reach to the knee, whatever, like it's one of those thin females, you're saying, God, I wish I had pouches like this all the time. I usually do hand sews now in those. If there's a question about what I'm doing, it's kind of the scenario I mentioned before, then I'll do a double staple technique.
That's very interesting. I actually had this question prepared for the special guest segment, but I guess it seems like it fits here well. With the progress and the success of biologics, one can argue that patients that get to surgery self-select themselves out to maybe have more aggressive disease. And so, do you think the colitis is purely a technical issue, or is it also because the patients we're seeing have more refractory disease? And does that make your decision of what operation to offer them?
Well, Evan, do you want me to take that? Because the cuffitis is, as I said, is a really big problem. There's many different factors that predict cuffitis, but the one that is medically refractory disease, that's one of the biggest predictors of disease of symptomatic cuffitis after ileopouch surgery. Now, you can argue, well, almost still all of them have medically refractory disease. That's still the most common indication. The use of the advanced therapies themselves have not been associated, with at least statistically, with the development of cuffitis. But it has. With the concomitant use of advanced therapies, laparoscopy has come about. So everyone's now attributing the potential increased incidence of cuffitis to the presence of the advanced therapies pre-op. It's probably not. It's because we're leaving longer cuffs, and longer cuffs are a well-known factor that leads, you can imagine, to symptomatic cufitis. I mean, that's pretty obvious. And so really, I don't think it has to do necessarily with the pre-op medication exposure, as opposed to potentially the lack, I mean, the leaving mucosa behind, particularly if the cuff is not done properly, then the surgery is not done properly.
Thank you.
Kevin, do you want, I don't know if you want to add anything to that, but
Yeah, I think my answer to that is yes.
Sounds like an
no,
excellent answer.
he thinks he's still my trainee. He's not.
I have to say, I still call some of my bosses, or previous bosses, by their full doctor title and name. I just can't bring myself to change. And for them, some of them, it's sort of nearing 8 years. So I'm in the same mindset.
Oh,
Um,
he's called me other things which I can't say online right now.
Just ch changing slightly again in terms of the direction of the questions. When I was a resident in Australia, we have to rote memorize a textbook for anatomy called Last Anatomy. I don't know if in America you have a different textbook, but particularly say the edition that I had to memorize was the ninth edition, and I recall the inguinal canal was 6 centimeters in everyone, I gather. And then I bought the next edition of the textbook, and somehow miraculously, the inguinal canal has reduced to 4 centimeters from 6 centimeters. The reason I tell this anecdote is, do you think when you talk about absolute measurements, and you've quoted another two studies that you based your study on, which is also based on absolute measurements, whether there may be a benefit of looking at ratios? So whether you look at the depth of the sacrum, or you look at the height of the patient in general, or the length of the torso. Have you considered that, or do you consider that clinically when you're faced with the patient now after you've published the study?
Yeah, we looked at a lot of pelvic indices, and we looked at this in a lot of complicated ways. We tried to do sacral curvature and what the diameter distance of it would be. We looked at it in not just straight up and down superior inferior fashion, but also we were calculating like the hypotenuse of triangles and tried to look at the vertical distance and or the horizontal distance, and none of it seemed to matter. Um, so I think, you know, it's, I think the important number is the mobilization length. I'm sure if you looked at the ratio between the mobilization length and the mesenteric length, that would be, significant. But ultimately, what we have to do is to figure out how to create that extra distance for the mesentery to travel. And I think if you look at our data, the fact that that number was associated with the number of vessels you had to take, was associated with male gender. I suspect that if we had a heavier population, it would have been associated with weight. So I think that is the number that in my career, I'm going to focus on clinically when I'm trying to figure out who is at risk for not reaching and who do I maybe need to have these conversations with in a more earnest fashion preoperatively. The one thing that we can't measure here that I think some people have is how much laxity does the mesentery have? That's a factor that I don't think you can radiographically measure, but maybe one day there'll be a metric that we'll be able to see.
Yeah, thank you. I guess I think all those points are very interesting. The laxity would probably be correlated with central obesity more than anything, and particularly more than BMI, perhaps, because as we know, the BMI is not a really good discriminator for where the obesity is. From a personal perspective, when I looked at the pelvimetry, one of the things that drove me insane was the position of the coccyx. And so if you measure to the coccyx, you just need a posterior coccyx versus an anterior coccyx, and it throws your triangles quite a bit. And so I then looked at the sacrococcygeal junction as opposed to the tip of the coccyx. But again, you're looking for objective measures, and it sounds like you're completely correct. Objectively, the only thing you can control is how well you can mobilize the SMA. There's a question in the chat about, I guess now that you have the measurements on CT, does that change your approach? Do you mobilize less? Do you mobilize more based on your preoperative views? Or do you sort of just have them as an interesting fact, but then still proceed with your usual algorithm?
I don't routinely check these lengths. I check them if it's a male patient, and if it's somebody who's heavier. Um, those are the instances where I go and I ask the radiologist to help me calculate it. Um, I don't, I think the way that I was trained, like routine retroperitoneal mobilization is the most important factor. And then it's really just about testing and seeing how much you got out of that and how much I still need. Um, but to me, the value of these measurements is in the preoperative decision making, operative planning, and conversation with the patient.
Yeah.
I agree, and I agree. The only thing I would agree with that is that, obese patients, I'm not operating on. I mean, you should not be operating on those patients. It's an elective operation almost always. Put them on a GLP-1. When they live with their stoma, I know this sounds crude, but every time they eat, tell them to look at their stoma, and because it's not going to disappear until they lose weight. I know it sounds crude, but it's true. And that usually is very, very easy way, not easy, a relatively easy way to kind of have them lose weight with the GLPs nowadays. But the ones that I think are problematic are the tall males. For example, those are sometimes very difficult, and sometimes I'll use these measurements, just like Evan said, in preoperative discussions with the patient. If you're in that scenario where the pouch doesn't reach, if you've had a discussion with them pre-op, you can say, well, do you want me to do an IRA? Do you want me to do an ileopatch rectal? Do you want me to back off and do something else? Come back another day. Those are the kind of discussions you can have with the patient based on, a relatively easy review by a radiologist of their imaging.
Thank you. Furthering two more questions. Furthering the point about the tall males, have you considered post-operative positioning in bed? Do you think that having them in sort of a beach chair as opposed to a bed where they have their knees bent or their hips a little bit flexed would reduce tension in the first few days after surgery? Is there anything like that that may prevent, post-operative tension on the anastomosis?
Voodoo.
Uh, yeah,
Fair
you,
I
enough.
think
ev-
that it's sort of like the voodoo we use when we do a perineal proctectomy and we tell the patients to not sit on it for a month because we think it's going to disrupt the anastomosis. I mean, give me a break. There's no way that, first of all, the patient's not going to stay like that for 4 weeks. That's number one. As soon as they stretch, they're going to theoretically disrupt it. So I think that's a nonsensical way to approach an at-risk anastomosis. You shouldn't be in that situation. Let's put it that way, if you can.
Perfect. Thank you. Now, just changing the topic a little bit, I just wanted you to comment from a DCR journal perspective, as sort of authors publishing a paper. I suspect you would have submitted it and you would have got some comments from the reviewers. What is your approach when you receive reviewer comments? How do you I'll backtrack. Sometimes I find it challenging to maintain the ethos of the paper that I'm writing and comply with some of the comments, which may not necessarily then maintain that direction of the paper. How did you approach this for this paper, and did you have any challenges of that nature?
well, I think my overall first approach is to read the email, close it, sleep on it, and then reopen it the next day. No, I thought the review for this was incredibly constructive, and it helped the paper quite a bit. A lot of the focus, the criticism, and the improvements that we made was the subgroup analysis. Um, I believe that came out of reviewer comments. Um, the focus on weight and why we didn't see weight as a risk factor in our population was something that I had done in the analysis, but I hadn't really put as much thought into. And at that time, I was a fourth year resident, and it drove me quite a bit to read the literature and really understand it. So it was very helpful for me for my growth. But I think the important thing is to just you can do what you can do, and if there's things you can't do, the limitations of your data set, you just have to say, you know, these were the limitations of the study, and there's not unlimited funding and ubiquitous access to information, and I would have loved to have all 420 patients that were in the J-pouch registry in this study, but the reality is only 22% of them had a reliable CT scan that we could use. And at the end of the day, I think we still got a very useful tool out of it. So it wasn't perfect, but it did its job, and that's what research is for.
Fantastic. Thank you for that. That's an excellent, I think it's an excellent answer. I'm sure our listeners will agree. So thank you very much. If there's no other points about the paper, we might move on to the sort of the special guest segment. We tried to feature someone in each of the journal club. Of course, there's few better than Dr. Fleshner. So I was hoping to focus on the bigger picture of pelvic pouch surgery in this. Because we've had such a great discussion, we have overlapped a few of the questions already, particularly in relation to the cuff. I'd like to start by sort of asking your philosophy on the difference between 1, 2, and 3-stage pouch formation, and whether you think that the sort of evolution of minimally invasive surgery, whether it's robotic, laparoscopic, or TME or whatever else will come next, whether that would impact on that philosophy of 1 versus 2 versus 3.
Well, first of all, in terms of the one stage, I literally have never done a one stage. I think conceptually that makes no sense to me. I think you're already at a high risk anastomosis in a patient who is on steroids, frequently malnourished, anemic at the time that we as docs get them, although we tend to get them sometimes now a little bit earlier because of our better appreciation of our docs and the value of our GI docs and the value of surgery. But a one stage procedure, I think that's playing with fire. And I think one of the reasons for that is that as much as patients don't want an ileostomy, we get that. I can take care of an ileostomy complication a lot better than a pelvic sepsis or a complete dehiscence of an anastomosis, which is quite frankly a lifetime problem, as opposed to a peristomal hernia that occurs in the future because they end up getting an incisional hernia from their stomach. So that's the reason why I sort of don't do one stage surgeries. In terms of 2-stage surgery versus 3-stage, very controversial. I still do most of mine now 3-stage. I have no problem doing them 2-stage in selected patients. The thing that I don't like is the modified 2, and personally. And the reason I don't like the modified 2 phase, for those of you who don't know what that is, it's basically the patient now has recovered from their initial total abdominal colectomy. They're off steroids. They're feeling well. They've regained their general health. The pouch now reaches hopefully relatively well down to the anastomosis, and you don't even do an ileostomy. And I think it comes back to what I mentioned before, is that I still can take care of an ileostomy complication a lot better than a leak. A leak, as all of us know, is a long-term adverse effect on function by far. Pouch failure, terrible quality of life. Everyone knows it, just like it is in rectal cancer. It's like I always like to say it's sort of like the Lars equivalent. They just don't do well down the line. And you just wish you sort of never did it, so to speak. And so that's the reason why I generally don't believe in the 2-stage. I'm sorry, the modified 2. There are, however, people, mainly the Europeans, who actually do, although there's some people and particularly Duke that are actually doing these modified 2s, but mainly the Europeans are doing it. And the rationale that they use, just so that you know, is that if there's a leak, they want to know about it. Because if there is a leak, they're going to go in and go after it with an endosponge or with various, TAMIS procedures to try to control the leak and then give an ileostomy then, which again, I think that's if they have a 15% leak rate, I think I'd rather just give the ileostomy and quite frankly, just bring out every patient if you really think that they're at high risk, just bring them to the endo suite. I do a gastrograph and enema on day 3 to see if you have a leak. I'd rather keep my ileostomy in place. So that's the rationale for me to not do modified 2s. But I can also tell you, though, again, without sounding too confusing, there are situations all of us have seen where we make our J pouch, we're happy with the way it looks. Let's say the patient's a little chunkier than like, or the mesentery is a little thicker than you like, and the stoma's not coming up well through the abdominal wall into the old stoma site. And now you're saying, what am I going to do? Well, your option is you can go higher up, but then the patient's going to get voluminous diarrhea and is going to have a fairly difficult time over the next couple of months while they're letting the anastomosis to heal. You're right. You can, in that scenario, if you're happy with the anastomosis, with the modified 2 has taught us, that you probably get away with it in those scenarios. So if you're in a scenario where you created your pouch and you can't bring the ileostomy up easy, do the modified two. Okay, put in drains, cross your fingers, hopefully get away with it, because that may end up being better for the patient than giving the patient an incredibly proximal ileostomy.
Thank you. Just following up on the drains, I remember reading an Australian study, I think from Sydney, about looking for bilirubin in drains. Do you ever look at specifically measure drain content? Obviously, with
I
bilirubin
don't.
being
I
enteric.
don't. People have done, they've done CRPs and all types of stuff. A lot of people, as you know, a lot of people just measure serum CRPs looking for that, looking for trends. So if you various different numbers, but usually by three, if your CRP is still over 150 or 200, then you know you have a problem. And those are the patients you might consider going back and doing just an exam under anesthesia. As I said, the Europeans do a lot of that. Doesn't really caught very much attention on this side of the Atlantic, interestingly, though there is some evidence that it might work. But I don't measure CRPs and drains. Drain is a whole other drain thing. You theoretically don't even need the drains. A lot of people don't even use drains. I was just taught to use drains, and it's one of these, what of old-fashioned techniques that I don't think I'm ever going to get rid of, even though all the meta-analyses have actually shown that when you use drains, particularly in rectal cancer, you increase your risk of pelvic sepsis. So, but still, I continue to use the drains. But no, I generally have not measured those types of things in drains.
Thank you. The other point you mentioned about the challenging loop ileostomy, I guess it'll be great to get your algorithm. So in that, obviously, if we're looking at least a two-stage, there would have been a trephine and an ileostomy there. How sort of connected are you to using the same trephine if you think that there is tension? And secondly, the other thing that's gone out of fashion are rods, which I've used in my training, and I thought they were great, but I can't even find a good rod anymore. So, what is your view on both the trephine and the rod?
In terms of the tray find, I will try my best to use the same site. Many of these patients are young females. They don't want to have another incision, another potential for an incisional hernia down the line. But again, if you're stuck in that scenario, all of us know, just like a typical board question, if you have a difficult stoma that you can't bring up to the abdominal wall, you can make a loop. You can, there's all, mesenteric selective division. But the other thing you can do is you bring it up higher up to the epigastrium, not the epigastrium, this in the right upper quadrant, left upper quadrant, based on it depends on where it lies, because usually, particularly in a relatively obese patient, there's not as much fat there. Again, you should not be in that scenario though. You should not be in the operating room with a big patient. So that's the reason why, in many ways, that's your fault that you're there, as opposed to the patient's anatomy. But I will always try to do the old stoma site. In terms of what was the second question again? I lost my
The
train of thought.
rod.
Sorry. Oh, the rod. Yeah. So the rod, I used to use rods all the time. I had similarly difficulty finding rods. What I now use for a rod is I use the outer aspect, the plastic sheath of a 14 gauge angiocath. You just cut it, and actually it's a smooth surface and leave it underneath. I don't use the rods anymore, except for keeping the stoma in place while I'm doing other things to make sure the orientation remains correct. I keep two coker clamps on either side of the rod and make sure, therefore, that they don't twist and therefore don't, quite frankly, mature the efferent limb wrongly or the afferent limb wrongly, depending on what I'm going to do. And then what I'll do is as soon as I put in the way I do my stomas, I do four quadrant sutures initially to orient it. And once those four quadrant sutures are in, then I'll just take the rod out and I don't use the rod anymore. I used to use the rod consistently. Patients didn't like it. It interfered with the seal of the pouch in the early days, I found. And not that we have big wounds anymore, but we used to have wounds that sometimes got contaminated with that. It was a problem. So that generally now has led me to not use the rods post-op, although sometimes, like I said, I'll use it intra-op to allow me to keep orientation of the bowel while I'm maturing, while I'm doing like a tap block or a drain or whatever I happen to be putting in.
Thank you. Um, I remember a story about Dr. Fazio's patient selection and the cutoff for the patient that would have a pouch extended as he became a more mature surgeon chronologically. Now, with yourself, I guess, as you become more mature, whether have there been any cutoffs that you have changed? You've mentioned Crohn's disease and pouches. How do you view that evolving? Do you think that will become more commonplace? Is that going to be a very selected area? Where do you see it going?
Okay, so in terms of the age cutoff, okay, I think age cutoff is very similar to what sort of we use like a colonoscopic screening. There's this whole almost dogma out there that says you should stop colonoscopy screening at 70 or 75, something like that. But why would I let my 90-year-old, who quite frankly can run laps around both of us, if that's a patient like that, die of a colon cancer? It's not commonsensical. And because of that, what I usually use, and I use it the same way in my pouches, I don't use it on age and years. I use it on physiologic age. You could be an unhealthy 30-year-old, you could be a 97-year-old and be healthy. Now, the oldest one I've done, by the way, is an 87-year-old patient who, by the way, lived for 12 years. And I know you think he had 3 bowel movements a day, did great, got run over by a bus. I mean, it's like, you can't make this stuff up. But he was doing great. But the point, I really don't think we should be limiting it just because of age. Now, you have to look at other comorbidities, obviously, and sphincter function, which are going to guide whether or not those patients are candidates. But if they otherwise are good, fit patients that can tolerate this and they're motivated, they should be able to have it done. I don't think there's a reason you should not pull that back for them. In terms of Crohn's disease, I have advocated the use of of these pouches for a long time in select Crohn's patients. And this is the reason why, okay? Let's presume you're a 23-year-old. You go to see Dr. Bolshinsky, who I have Crohn's disease, and Vlad said because I'm 23 years old, I have Crohn's disease in my colon, my rectum's involved. I need a total prostatectomy and endoleostomy. I don't know if you guys know, but the most important thing that patients worry about of Crohn's, they don't care about cancer. Not they don't care about, they're not worried about that. They're worried about the stoma. And now you're giving them the worst possible thing they've ever discussed. But then they come to me and they say, yeah, Vlad wanted me to do this, but so you're telling me that, and we've published this, that we could do J pouches in those patients. 50% of them approximately end up with inflammation back, which is high. But the vast majority of them now are controlled with advanced therapy. That's the game changer that we have now that we didn't have 20 years ago. So yes, you get inflammation back, but because the advanced therapies work, and many of them work after surgery, even though they've been on them preoperatively, the overall risk of pouch failure is 4%. So this young woman's looking at me and say, you have a 4% chance of a stoma, but Vlad is giving me a 100% chance of a stoma. Granted, I got to be on advanced therapies the rest of my life with appropriate patient counseling, et cetera, et cetera. I'm going with you. I mean, I think that's I understand I can understand where the patient's coming from for that. I think all of us could. Again, with appropriate counseling, that's the key. Patient, shared decision making in terms of what they have to expect. Prophylactic use of advanced therapies, aggressive pouchoscopies, and realizing that you're not out of the woods. Not necessarily, by the way, that you're out of the woods, even when you have ulcerative colitis and you have a J pouch. As you know, we can all get inflammatory sequelae. Any of those patients get pouchitis and cuphitis and de novo Crohn's disease down the line. So that's the way I've sort of addressed the concept of Crohn's disease in these pouches. So yes, I'm a big proponent of them in select motivated patients.
Thank you. This is a wonderful discussion. Very grateful to have your time. The final question I have is related to kind of the different configurations of pouches, and that married with the fact that probably because of the biologics, we are at the moment doing less pouches. I assume. Now, hopefully, I'm excited about your take on Crohn's. I'll be all for doing more pouches in future again. But, there's the J pouch, the S pouch, the W pouch, which I guess is more historical than anything. I've never seen one. The H pouch, again, I've only seen one of those. And in training and personally, I've had a lot of exposure to pouches, but most of them were J's. And so, what is your expectations of young surgeons coming out and offering pouch surgery and the challenges of sort of the familiarity in the different configurations, and is it even required anymore, or is the J pouch really kind of sufficient for someone to offer pouch surgery?
Yeah, I mean, I think the H's and the W's have gone by the wayside, and it's not because they're just technically kind of cumbersome to perform. But in the early days of J pouches, there were really actually some good trials that compared the various pouch orientations. And they found that particularly the W's did not work as well as the S and the J's. And therefore, most of us choose them between a J and an S. Most of us choose the J, quite frankly, because it's easy. I mean, it's just a fancy side-to-side anastomosis, anti-peristaltic. They were kind of used to for putting, two ends of a small bowel together, whatever. Just make an anti-mesenteric enterotomy. That's basically what a J pouch is. So I think all of us feel comfortable. But having said that, though, just sort of what we were mentioning before, if you are length challenged and you're stuck there, you have to know how to do an S pouch because the S pouch will administer at least another 2 to 3 centimeters for you, which could be critical to get a tension-free anastomosis. So if you're stuck in a scenario now where you sort of brought your J down, you haven't created it yet, but you realize you're going to be challenged here, you have to know how to do an S pouch. An S pouch is, you can look on YouTube, it's just fancy sewing. It's fancy, again, 3 loops instead of 2 loops. But it's basically just fancy sewing with a little bit of an efferent limb that you're leaving. That's the outflow tract, which should be short, leading right to the anal canal. But you get that extra bit of length that'll help you, as I mentioned, for that tension-free anastomosis. So you should be very comfortable doing J's, but you also have to be comfortable, just like anything in surgery, with a bailout, and your bailout is your S's, and you have to feel comfortable doing those.
Well, thank you very much for such thorough and detailed answers. I'm delighted that we have this recorded, and I'm sure it's going to be very useful for many people, both in the ASCARS community, the DCR community, and internationally. Dr. Adams, thank you very much as well. So a great summary and great contribution. So yeah. This is the end of the recording. Please tune in next month. We're having a debate about the sort of the validity of surgical intervention for internal rectal prolapse. So a radically different topic for me, a far more scarier topic personally. But yeah, I'm looking forward to that. And again, thank you very much. It was a great recording. Have a good rest of your day.